Hey everyone! Today, we're going to tackle insulin dosing for an average 70-kilogram patient. We'll go through both long-acting and short-acting insulins, discuss dosing adjustments for insulin-sensitive and insulin-resistant patients, and explain how sliding scale and dose correction work. Plus, we'll explore what happens when a patient has kidney disease. Let's dive right in. First up, let's talk about long-acting insulin, which is used to maintain baseline levels throughout the day and night. Some common long-acting insulins include insulin glargine, Lantus, Basaglar, insulin detemir, Levemir, and insulin degludec, Tresiba. For our 70-kilogram patient, the typical starting dose is 0.2 to 0.3 units per kilogram per day. So let's do some quick math. This dose is usually given once daily, often at bedtime, to provide a steady insulin baseline. Now let's discuss short-acting insulins like insulin Lispro, Humalog, insulin Aspart, Novolog, and insulin glulicine, Apidra, which are taken before meals to control post-meal glucose spikes. For our 70-kilogram patient, the starting dose for bolus insulin is typically 0.1 to 0.2 units per kilogram per meal. Let's calculate that. This dose is adjusted based on the patient's carbohydrate intake and blood sugar readings. If the patient is insulin sensitive, like many children or some type 1 diabetics, we start with lower doses around 0.2 units per kilogram per day for long-acting insulin, and on the lower end for bolus doses. In contrast, insulin-resistant patients, often with type 2 diabetes or obesity, may need a starting dose of 0.3 to 0.5 units per kilogram per day for long-acting insulin and 0.2 to 0.3 units per kilogram per meal for bolus insulin. Next up, sliding scale insulin is commonly used in hospitals to adjust insulin based on real-time blood glucose readings. For example, if blood glucose is 150 to 200 milligrams per deciliter, you might give 2 units. If it's 200 to 250 milligrams per deciliter, give 4 units, and so on. For correcting high blood sugar, we use the correction factor, also known as the insulin sensitivity factor, ISF. A simple way to estimate this is using the 1800 rule. So if the total daily insulin dose is 50 units, this means that 1 unit of insulin will lower the blood glucose by about 36 milligrams per deciliter. Now let's talk about how insulin is processed. It's primarily metabolized in the liver and kidneys. About 50 to 60% is broken down in the liver, with the rest cleared by the kidneys. But what happens in patients with kidney disease like ESRD or CKD? Since their kidneys can't clear insulin effectively, insulin stays in the bloodstream longer, increasing the risk of hypoglycemia. That's why doses often need to be reduced, and close monitoring is crucial. So, to recap, for a 70-kilogram patient, long-acting insulin starts at 14 to 21 units daily, and short-acting insulin is 7 to 14 units per meal. We use the 1800 rule for correction factors and adjust doses based on insulin sensitivity. Remember, kidney function affects how insulin is processed, so dose adjustments are necessary in patients with kidney disease. And there you have it! Insulin dosing can seem complex, but understanding these basics makes it much easier to manage. If you found this helpful, don't forget to like and subscribe for more clinical tips. See you next time.